So what I thought I'd do now, just to make it practical, and just checking in the chat if there's any. Great. So, oh, thank you. So there's some comments. Thanks, Richard. The 5 ml estradiol valeriate vial from Fagrin is currently $589 retail. Thank you very much. And I think it's about $100 postage. So you'll end up paying sort of close to 700 Rand. And they do last, especially in the beginning when you're using like 0.1 ml. Then a 5 ml does last for 50 weeks potentially, or at least 6 or 7 months. So it actually becomes quite affordable from a monthly point of view. I'm just looking at the second question. In trans men who are on testosterone therapy, how do combined hormonal contraceptives interact with exogenous testosterone? Are there any clinically significant effects on efficacy? Also, what type of contraceptive would be most appropriate? Great. So thank you very much. Very good question. So there doesn't seem to be any problems in terms of combining contraceptives with testosterone. But you're obviously not going to use estrogen. So we wouldn't want to combine estrogen and testosterone. That's just mad. But the progesterone, there doesn't seem to be any issues in terms of progesterone with testosterone. So there's the 2 options that I mentioned earlier in terms of suppressing menstruation actually would be great options. And that's also, if they are still menstruating, you also know that there's still a risk that they obviously might be fertile. So the mini pill, if they're happy to take a tablet every day, and I must say, these patients are very motivated. We normally do not find that adherence is an issue because your patients are desperate for these changes. So it's a very different kind of patient group that we're trying to convince to take their treatment. They are very enthusiastic. But the other option, actually, I think the Marina IUDs is a very nice option. I'm not so keen on the Depo-Provera as an option. So good question, thank you. So I've created like a little case study, which is it's a and it's actually it's not an actual couple, but I do have a couple where I've got a trans man and his girlfriend is a trans woman, and they've started on hormone therapy together. So they're both 20 years old in this particular example. This example is not based on them, but they've met through the trans support group, and they've actually already done a lot of their own reading and research. They were already socially transitioned when they met each other, and they both now very keen to actually go through hormone therapy. So they present, for example, at my clinic, and I'm going to show you how we're going to manage these 2 people together just through all the stuff that we've just discussed, just to make it nice and practical. So the first thing we want to do is we want to have a discussion with each of them in terms of our informed discussion. Remember our informed consent form? We've got that lovely informed consent form that we've talked through earlier. And we want to talk a lot about all the risks and benefits, side effects, and all those risks that we mentioned earlier. And with him, we need to talk about egg freezing. So egg freezing is expensive. And the problem is not even the harvesting of the eggs, which is a whole mission in its own right. And quite often before they harvest the eggs, they actually give you extra hormones, which is also a challenge. But also then you have to pay every year to keep them frozen. And that's where the real costs come in. So this is almost not achievable for even some of your better resourced patients will struggle with that. But if they are considering it, then you actually don't want to start them on testosterone until they've done that process. And then, of course, we're going to go through the timelines with Sipho to help him understand what exactly is going to be expected. And they find this table for them is a key part of being able to manage that expectations. So the same with Macy. We want to talk about Macy, what's going to happen with her feminizing treatment. And we're going to now again talk about the side effects. We have to talk a lot about what to look out for in terms of VTE, just the safety signs for that. And again, here we talk about preservation of sperm. This is definitely cheaper and obviously much easier to give. But again, you want to sort that out before you start your hormone therapy if there's something that she wants to explore. I'm not sure of the actual costs. If somebody does know, please put that in the chat. And again, for Macy, we've got a different table and looking in terms of what kinds of things she can expect. And the reversibility is very important here. And we've really seen, You know, I've got patients, so I'm sitting in East London, and the clinic in Gqeberha has not restarted yet. They are working very hard and trying to get that up and going, but we've had patients now without treatment since March of this year. And all of this changes that they've been so excited about, and that has been such a celebration for them. And now the extreme distress caused by watching most of these things reversing. And as I said, the big things that we got to worry about with the mass, you're going to end up with a beard, and with the feminizing treatment, you can end up with a breast. And that's partly why none of these are medically dangerous to our patients, obviously, in terms of long-term effects. And from that point of view, medically, we're quite happy with that benefit risk discussion ratio. And then your baseline assessment. Remember, we talked about all that previous medical history and family and surgical history we want to talk about. I've mentioned screening for mental health conditions. If most of you are going, what's a PHQ-9 or what's a GAT7? Please go and Google it, family medicine. So this is some excellent tools in screening for depression and anxiety. And I think we should be routinely, you can do it too, there's a PHQ-2 and a GAT2. That's a great way to screen whether there's something to look out for, and really look for substance abuse and also the use of substances with sex. Take a good contextual history. So we need to understand, again, family physicians, where do they work? Who is their families that are supporting them? Who's looking after them? So we want to know transition is not something that's a quiet thing that you're doing. It's a public event. And for some reason, people quite often all think they need to have a say. Apologies. You need to know how's the family about this. Start thinking about what's going to happen Christmas time. Where's Granny at with all of this? Are we telling Granny or are we not telling Granny? What are you going to tell your boss? What are you going to tell your colleagues? What's going to happen at university? So there's a lot of factors here that it's helpful to explore the patient with. And most of the patients are already in that social transition phase and is already facing all of these dynamics. So physical examination, just think contraception. Take your blood pressure, your pulse, don't do genitals. And if over 40 years old, then especially in our trans men and over 35 in our trans women, we want to do that cardiovascular risk screening as well. My connection unstable, maybe it's back. And remember to screen for HIV, TB, do a pregnancy test for CPOR before we start that testosterone. And then we've got our baseline bloods, and we just got the same set we do on all our transgender patients. That makes it easy. Baseline HB, baseline creatinine and EGFR and potassium, an ALT to check for the liver, check your finger prick glucose to make sure there's no diabetes, do a total cholesterol, and do an RPR if sexually active and indicated. And then also a hepatitis B can also be considered here if they might be at risk. So when we now we've done this whole discussion, we've taken a nice history, and now it's important we're going to give them some information leaflets to go and read all the stuff you've just talked to them about. And normally I find they've already done quite a lot of reading themselves. And now you need to decide, who do I need to involve in my multidisciplinary team? So in my clinic, it's just little me. There's nobody else. I don't even have a nurse at the moment. She has been amazing in providing some support with a social worker that can pop in. But I do have people. I've got a counselor at Duncan Village Day Hospital. We've got social workers within CMH, for example. I've got affirming psychologists and psychiatrists within my local regional hospital. So I need to know who's my team and which of these people have had some training. So you guys are on these courses. We're going to start identifying who are people that we know are gender affirming, which occupational therapist is going to be able to understand about pronouns, for example, which speech therapist has done a bit of training on how to do gender affirming speech therapy, for example. Who's our social worker that can support if there's social issues that need to be sought out? Does this person need some extra help in terms of their journey? And I think for me, the exciting thing at the moment is starting to find all these people in our districts who are our gender affirming practitioners that can assist these patients. There might be some patients, though, where actually they're fine. They come from a very supportive family. They've already socially transitioned at work and everybody is behind them. They don't have any anxiety or depression. And actually they are 100% on board, and then there is no need to involve anybody else. So with our couple, we're now going to see them 2 to 4 weeks later after their first visit. Usually it's 4 weeks. You're going to revisit now the discussion points about everything. We're going to look at those blood results, make sure there's no contraindications. And what I do is I go through the information leaflet and I get them to actually explain back to me what they understand about what is going to happen. And then we actually sign that informed consent form. So we now actually want to initiate treatment. So it's that simple. If you've done your informed consent process, you've given them written material, you see them at the next visit, you've sorted out all the mental and social support stuff, there's no reason to not start treatment at this point. So for CPOR, we're going to start him on that testosterone sapionate. As I said, in private, $500 to $600, about $50, $60 a month in public sector. We're going to start him on 0.5 ml subcutaneous every week. And if he was a very small or quite sensitive to medicines, we might even start on a lower dose. So for Macy, we want to initiate her on estrofem 2 milligrams, because that's all we have in the public sector, plus that spironolactone. We can do 50 milligrams and jump up to 100 quite quickly, or you can do 25 and jump up to 50. In your young people, you're a little bit more aggressive. I must say I like to do the 25 and jump up to 50. Or if she is happy to go on the subcutaneous injections, then you can order that estradiol valeriate through Fagrin and give her a private script to go and order that. So you give them then an NHLS form. You explain to them that 1 week prior to their 3-month visit, so you can either do a monitoring at 1 month, but you're going to do their hormones at the 3-month visit. So at that 3 months visit, 1 week before we see them for CPOR, we're going to do a total testosterone level. We're going to do a creatinine, an ALT, and that hemoglobin. For Maisie, we're going to do an estradiol level. We're going to do potassium and creatinine and that ALT again. And remember, for CPOR, you're going to circle male on his form. For Macy, you're going to circle female on her form, so that will give you the levels that you are targeting. So for 3 monthly levels, as I've mentioned, when you ask them to do those hormone levels, make sure you do a peak level. So for CPOR, we're going to say do it 2 days after your injection. So if you always inject on a Sunday, then go on the Tuesday for your blood test. And for Macy, do it about 3 to 6 hours after taking your medication in the morning. So there's a level which is quite helpful. If you want to, can I see I'm unstable? Hopefully fine. So your estrogen level, you want to aim for about 700 to 800, but definitely don't want to go more than 1,000. And I must say, when you get the hormone levels back, it's a bit confusing because they give you levels for like the luteal phase and the follicular phase. And so 700 and 800, less than 1,000, that's a nice safe dose of estradiol, nice safe estradiol level. And you can do a testosterone level for Macy at 6 to 9 months and then target the female level for testosterone or get it under 2. What's important is the patient needs to feel that the dose is working. They need to feel happy that their body is busy going through these changes, and the doctor just needs to make sure that the dosing is safe. That's your job. More is not necessarily better. Remember, I talked about testosterone actually turns into estrogen and causes gynecomastia. So that's useful to tell your patients, because sometimes patients are quite anxious that they want to get to the maximum dose to get the maximum effect. But hormones don't really work like that. Hormones just stimulate receptors, and then the body starts undergoing these changes with those receptors on these organs being stimulated, and more is not going to necessarily cause more stimulation. So when we review the dosing with CPOR now, say we see him 3 months later, we're happy, we're going to look at his male testosterone levels as a guide, and if we want to, we'll go up by about 0.1 or 0.2 mils at a time, till we're going to get every 3 months, till we get him around 0.7 to 0.8 mil, or if we're able to do hormone levels, then we can use that male testosterone level. If you've got somebody where mood swings and aggression is an issue for whatever reasons, then you might decide to go very slow. So you might even start with 0.1 mil, go up to 0.3 at the next visit, go up to 0.5. So we have quite a lot of control over how quickly you want this puberty to kick in. For Macy, at the 3-month visit, we're going to put the estrofen up to 4 milligrams. We can then put the spironolactone up to 100 if it's not yet 100. And then at the 6-month visit, we'll go up to the estrofen 6 milligrams, which is usually the dosing that does the trick. Or if you're using estradiol, you're going to increase by that 0.1 ml every 3 months. And again, some people are quite sensitive and they might not even need a very high dose. And most people, 0.6 to 0.8 ml is plenty. So we're going to see them every 6 months until they're settled on that dose. And then once they're settled, usually by the time they reach the 6-month visit, then you can do a 6-monthly script like we do with our contraception. And every review visit we see them, we're going to re-talk about the side effects and complications. We're going to always re-talk about the reproductive decisions. Talk about contraceptions. Has things changed? What is your feelings now? What do you think is going to happen? And remember, you've got probably quite a bit of time before they're going to become permanently infertile. Always do those mental health screens and substance abuse screens. Our transgender patients are very vulnerable, mainly because they have to cope in a world that's not very friendly. And then when relevant, check for metabolic syndrome. That means check waist circumferences. The BMIs are so irrelevant. Do a blood pressure, do a waist circumference. If you are concerned about metabolic syndrome, screen for diabetes and dyslipidemia. And then, of course, very important, we're talking about sexual and gender health, talk about STI prevention, pre-exposure prophylaxis, HIV, etc. So that's all my things on hormone therapy, actually. And feel free to add some questions into the chat. But we've got a last couple of slides. At 7:05, we're going to finish